Um, okay, for those of you who are just joining us for the first time, this is Indications, and this is um, basically a webinar that Jan and I started putting on just to try to do some work on medical education for those who are in the medical sales industry. And so every month or so we get together and chat about a different topic. And tonight we're talking about tibia fractures, and particular talking about intramedullary nailing tips and tricks. So Jan, just for background, I work in Middle Tennessee. Jan and I are both foot and ankle. Jan's also trauma, and so I think in terms of the conversation and expertise, Jan definitely has me on that one, on this one, in terms of insight and stuff. One of my partners, Bethany Gallagher, is jumping on as well, just to give some insight as well. So I think you'll get some different perspectives on managing some of these fractures, and we've included some different cases so you can kind of get a sense for some of the tips and tricks that you want to keep in the back of your head as you're getting into some of these cases. And the goal is for you to go through different cases and to kind of have an idea of some of the challenges that you might be facing, how to look at the x-rays, and maybe how to anticipate those things so that you can have those options available for you on the back table, or in the core, in case you get into some of these tricky situations. If there's questions that come up, we do want to make this interactive, so just go ahead and put them into the chat, and I'll kind of be presenting. Jan will be watching the chat a little bit, and then we'll try to call those questions out so we can get to them as we get going with things. So thanks everybody for joining. Should be a good discussion tonight, and we should be able to have some be out of here in about an hour or so. Don't you think the Lions are going to win tonight?
They're favored, but you never know. So, but that's the line. They're favored by 7.
By 7 points. All right. Well, it's probably more dependent on the fantasy football situation as much as anything. Okay, so we'll get started here. Just to, as a cursory outline. First off, I'm going to go back for a second. A lot of these animations were put together by one of our residents, Jacob Schultz. I want to give him full credit. He does a great job with putting together some of the different animations to show some of the principles that we're talking about. So, if we talk about the different types of fractures, you have tibial plateau fractures. We're not talking about that tonight, but that's, an intra-articular fracture of the proximal aspect of the tibia. We are going to talk about tibial shaft in terms of the proximal, because those can present some unique challenges. We're going to talk about midshaft tibia fractures, and we're going to talk about some other distal tibia fractures as well. So some different things that we can talk about when it comes to the tibia. Ankle fractures are certainly out there. We're not going to talk about those. And then pilons as well. And you could have a case for some extreme nailing in some of those cases as well. But we're going to stick mostly to the proximal tibia, the midshaft, and the distal tibia tonight for the discussion. Okay, Jan, this was a case that you sent. So we try to make this based off of case-based presentations. So this is an x-ray that you had, a case that you had presented. I'm assuming this is a high-energy motor vehicle situation?
Yeah, I believe so. I forgot exactly, but yeah, this is a high energy tibial shaft fracture.
Looks like rotational a bit in nature, perhaps.
Yeah, and I think what you're saying is, if you look at the x-ray here, gosh, I can't get the point. Oh, here's the pointer. Sorry about that. Why is it not? So if you look right here, it's kind of a spiral oblique, and you're right. So that gives it more of a rotational setting. You can also see the fibula as well. Many times you'll see a fibula fracture that's actually much more proximal with these types of injuries. But here we have one at near the same level.
So, assuming youngish person in this situation?
Yes.
Okay, so young person, we'll say in the mid-30s, rotational injury, tibia fracture, mid-shaft, slightly distal to the mid-shaft, and then a spiral fibula as well. So here's some ankle films. You always want to get, midshaft or the tib fib films as well as ankle films. Anything here that you want to call out, Jan, on this particular case?
Yeah, I think you could see here, it's a little bit harder to tell, but on some of the x-rays, you can almost see air on the medial side of the tibia, which is very common, as the medial side of the tibia is pretty sub-Q. So this is an open fracture, and you can see air here on the lateral that's tracking in the soft tissues.
Yeah, that's a good call. And I think that's important to note that a lot of times these are going to be, with these high energy fractures, they're going to be open as well. So let's talk through, management. I think, in terms of the call tonight, maybe we're not necessarily talking as much about some of the management, but, we have a couple ways we can manage these. You could manage it with a cast. That used to be a way that things were managed. Traction, external fixator. And then we probably need to talk about, obviously we're talking about an intramedullary nail. So that's going to be one of the things that's going to be pertinent that we're going to be discussing. So options for intramedullary nail, Jan, talk to me about, the two approaches. I think everybody's talked about this quite a bit in terms of like suprapatellar versus infrapatellar approaches. And when we came through training, a lot of things were infrapatellar. That's pretty much all we did. And now everything seems to be suprapatellar. Is that been your experience as well?
Yeah, I mean, I didn't do a suprapatellar nail until I went to fellowship. So that would be in 2010. So all the nails were done. All the nails I did previously were infrapatellar. And the suprapatellar nailing was made more popular by certain instruments because initially it was described by Paul Ternetta as semi-extended nailing. But he would do a full arthrotomy. And if you go back to the other image, go back to the next image.
Okay.
You could see here that this is like a pretty small suprapatellar approach where in this case, the quadriceps tendon is split in line with its fibers, but it's done, basically percutaneously. But the way Ternetta originally described it was doing a full arthrotomy in this position. And, but then when the instruments kind of, some people started when they transformed the way we do these nails. And now if you ask at an AO course or OTA course, it's basically almost 100% of residents are doing a suprapatellar nail as opposed to infrapatellar nail.
And the infrapatellar nail, talk about that too, from a perspective of, the tibial triangles and hyperflexing the knee and getting exposure for that. Cause that's always a big challenge. And that's a big reason why it's so helpful to help, get your reduction and ease of instrumentation.
Yeah, no, absolutely. And I think here, you had so suprapatellar nailing is semi-extended. So the imaging is very easy with the X-ray techs, as well as for that, just in the entire team. It's a regular AP of the knee and then a lateral of the knee. In the infrapatellar, you got to hyperflex the knee, and it's much harder to get the appropriate imaging as well as hold the fracture at the same time, or hold the fracture reduced, excuse me. So I think that's one of the major reasons it's falling out of favor. We'll go over how there's some advantages of the semi-extended or suprapatellar nailing technique, but a lot of it has to do just with the imaging is just a lot easier. I did one the other day, infrapatellar nail. I forgot the reason why. And one of the residents, the junior resident, is a third year, thought I was basically, they're like, oh my God, that approach is like, I didn't know you could do a nail like that. That's a new way. That's the old way of doing it. I was like, oh God, I feel old now. So
yeah. Any reason? Okay, so obviously there's a reason to do an infrapatellar nail now, but what kind of things would make you lean that way?
So infrapatellar,
Infrapatellar.
Infra, you said, yeah. So I think if there's a lot of like abrasions or some type of soft tissue injury superior to the pole of the patella, or I couldn't make a good, an incision easily, or I would think it was threatened skin, I may choose to do it infrapatellar. But I think those reasons now are few and far between. I mean, you can still, you could cheat your incision medial or lateral if you were going to suprapatellar. You can, there's a lot of techniques you can use now. So there's becoming less reasons to do it that way.
Yeah. Yeah. It seems like it's not that common. That's for sure.
No.
Okay. So indicated for debridement of the open right tibia fracture and then intramedullary nailing in this case. And did you put this X-Fix on at your institution, or is this something you used for maintenance of reduction?
Yeah, so a lot of times I'll do this for maintenance of reduction if I'm working alone. It's called traveling traction. So you put a transfixion pin, basically you make a box frame. So you put a pin proximally in the tibia that can be used as a blocking screw or blocking wire, and then you put one pin in the calcaneus, and it helps you hold. It's the assistant that doesn't get tired. So this is just like using a femoral distractor or like a fracture table.
Mm-hmm. Yep, it's a nice tool. And when you talk about putting it as a blocking screw proximal, your pin, your Schanz pin, is that that's then posterior to where the trajectory of your tibial nail, correct?
Correct. Yeah.
So something that's useful to have available. And then, femoral distractor is another tool that can be used in a similar fashion as well. Okay, so we are talking about intramedullary nailing. Let's talk about starting points. I think that's always important to know. Start points, pretty much very similar from an infrapatellar to a suprapatellar, but probably a little bit easier with the suprapatellar. Wouldn't you agree?
Yeah, and it's basically the same start point. It's just how you got there. But it will be the same radiographic start point no matter which way you go.
Yeah. Okay, so start point. Do you agree or disagree with this animation here, showing just kind of on the lateral side or the medial border of the lateral tubercle?
That's how it's taught, traditionally. I also just look how it's going into the shaft. So I want to just make sure I'm going straight down in the shaft. So sometimes you're just a little bit more medial to that. It's really key here to look at your rotation of the fibula when you're getting these x-rays, and make sure you have a good AP of the knee, because that can really fool you. And you can, if someone's ever in the operating room, if you just turn a couple degrees one way or the other, you can get the plateau will change. The demographics of the plateau will change quite drastically quickly.
Yep, I think that's important. And same thing on the lateral view, here as well, that on the lateral view, you want to make sure that you are, and here's an x-ray kind of showing the same thing. And then on the lateral view, you're kind of just off that kind of anterior ridge there of the tibia. So you agree with that?
Yes.
Okay. And you can tell there, it's probably a little bit easier to achieve that through a suprapatellar approach as well. Okay, so tell us about your tips and tricks in this case for obtaining your reduction of this fracture.
Yeah, so since the fracture was open, it was quite easy once it was debrided just to clamp it. So that's just holding the fracture reduced. You can see the courses are lined up overall on the far lateral view. And you can see on the far right view, you can see on the lateral view here, though, that there is a fracture line going through the joint.
Yeah. Did you have any sense of that on the initial pre-op x-ray? No? So you saw it on the fluoro?
Yes.
Now, how often are you getting, I know they talk about getting a CT scan in some of these cases. How often are you getting a CT scan?
Almost 100% of the time.
Almost 100%. So what was you want? What did your rep have what you needed to manage that posterior malleolar piece?
Yeah, so yeah, I always have available a small frag a set as well for these types of injuries, because I anticipate that there might be a posterior mal or something that I need to fix. Sometimes you also have to fix the lateral malleolus. In this case, 2 screws were placed distally before the placement of the nail. And then these are cannulated screws. You don't have to use cannulated screws. You can use, just solid screws as well. But here, just, basically holding the joint reduced and compressing it before putting the nail down.
Yeah. Can you draw out really quick that posterior malleolar fracture there, Jan? It's sometimes a little bit hard to see. Yep, you see it there, and then you see it extend up here, up into, or I guess I don't know if you can see my cursor or not, but it comes up that all the way up into that. Yep, Jan marked it out there. All right,
Yes.
so 2 screws from anterior to posterior. And let's see here if I can advance the slide. All right, and so now you have your fracture. It looks well reduced, and that's your post-op, and that looks great. I think that's really well done. You have you put 3 screws distally into the nail there. Is that usually your construct, or is it depends on where the fracture occurs?
It depends where the fracture occurs. Usually I only use 2, and this is where I'm really strict on it. When you use this 3rd screw, which is the A to P screw, you have to be very careful because of the neurovascular bundle anteriorly, and people get very irritated with their tibant tendon, even if you don't hit the neurovascular bundle, hopefully. This is a screw that's often needs to be taken out later on just because of soft tissue irritation when the patient starts dorsiflexing their ankle after they're healed.
Yeah, yeah. The medial screws can be prominent too, sometimes too.
Yeah.
And then, yep, so again, some more post-ops. All right, another spiral tibia. Here we go. Here's another one. This one.
Someone mentioned who's use of the end cap, and I don't know, do you use an end cap for these, Nick?
It depends. A lot of times I will, just in case I have to come get them out again later, but it's not routine. How about you?
Yeah, so for tibia nails, I think I've used like 1 in my career. So because if you, especially for open nails, if you have to take it out, it's a lot easier to take it out without an end cap in. Because you could you find that you basically, I mean, there's different tools to remove a nail, but if there's an end cap in there, you have to actually take that end cap out to remove the nail, right? To use the nail extractor. And so you can't strip that end cap screw. But otherwise I just ream it and cross thread it, the extractor to take it out.
Any reason, I mean, so then the reason to use it would be if you want more length on your nail. Is that when you would use it?
No, some nails, so not so much on the tibia, but like a TTC nail or a distal femoral nail. Yeah. If you place an end cap, you make almost a fixed angle screw, because that end cap will push against the closest screw to it. And so that screw can be more fixed angle. So if I'm worried about fixation in a distal femur or like a TTC nail, I'll use an end cap for those reasons.
Okay. Okay. Bethany, do you use an end cap?
Well, I was the one that put that, because I would have probably used one, but more because of what you said, to find it later if you're taking it out.
Yeah, but your point, that's a good point. Let's see, I think Brandon jumped on here. Brandon, do you use an end cap on your tibial nails? He's unmuting, or he can't hear, or he's ignoring me.
Hey, sorry, did you ask me a question? I'm just getting out of my car, sorry.
Do you use an end cap on your tibial nails?
I don't, for the same reason that Jan said, is that it's I find it just makes it more difficult to get it out, because then I've got to take 2 things or thread 2 things into the top of the nail in order to get it out. I got to find the end cap, thread that, or get the driver in that, take that out. And then after that, I've got to thread an extraction device into the top of the nail to get that out. And the use of an end cap, I haven't found to be a guarantee that then you just easily slide an extraction device into the nail. It oftentimes still you have to ream out a pathway to get the nail out, even if you put an end cap on it.
All good points.
Yeah, I want to start a campaign of stop using end caps.
Okay.
Yes, exactly.
Good.
I'm on board.
We should make some. You should make some hats. Please.
I didn't know if you wanted to talk like on that starting lateral you have. You have that honeycomb like pin thing to orient your, like you put in an entry wire and you put in another one on the first lateral you had, because that's really useful to have around too.
Oh, you're talking about the like that, what do they call it, the Gatling gun?
Yeah, the Gatling gun.
Yeah, do you use that, Jan and Brandon?
Well, you had the lateral, the first lateral, he had it
Yeah.
with a starting pin.
Hopefully everybody knows what that is, but that is another helpful tool to use. All right, so another case, a midshaft tibia fracture. This fibula fracture is a little more proximal, oblique nature. You can see that you have tib-fib films here and a CT scan this time. Was there something on the X-ray that made you suspect this, Jan?
No, I mean, my standard is to get a CT scan for spiral distal tibias. So that's, and that's, looking for specifically an ankle injury with this.
Okay. Yep. And what percent would you say that occurs in? 20%, 30%?
Yeah, the literature says 30%. I think I don't know, in my experience, it seems like if you look close enough, it's almost near 100%.
Seems like
but I mean, it's how clinically significant they are, who knows? But you a lot of times we'll find something by the ankle. There might be a little Chaput fragment or other thing going on that you didn't see on your regular X-rays.
Yeah. Okay, so here's our films, and we got a CT scan, and you can see that there's this distal tibia fracture on the posterior malleolus right here. So certainly worth managing that, or knowing about it, so that you can manage it. All right, another traveling traction.
Yeah, this is actually the same thing. I mentioned it, showed in the other case, but I'll use it many times. It's just easier to hold the fracture reduced for traveling traction, especially if you're by yourself. And then this was done, with a percutaneous clamp. It was not an open fracture. So a lot of these spiral thirds, you can use a clamp. Some people will, if it's open, it's a lot easier to clamp, but this will many times be able to kind of be worked in to get it reduced.
Can you talk about where you put that, like the types of clamps you like to have around, and then where do you want to put the clamp on? I mean, obviously it depends on the fracture, but there's a bit of a strategy to, being in a safe zone so you're not injuring any of the neurovascular bundles that are so close to the tibia.
You're correct. So, I mean, medially, you're usually safe, right? Because there's a subcutaneous border of the tibia. So as long as you don't plunge posteriorly, so that means in the back of the tibia, you don't have to worry about the vessel. When you're going more anterior and anterior lateral, you have to be much more careful. And that's when I will where the fracture is, I kind of pull traction, and then I'll get an X-ray and mark out where I want my clamp to be based off the fluoroscopic views. And then I make small incisions and spread down with a hemostat, and then place a clamp first laterally because I want to just, basically bluntly go with the clamp to the tibia. And then medially, I can have, obviously it's much more protected immediately. And then I'll place I'll take the other tine of the clamp. I usually will use a speed lock Weber. This is what's called a speed lock Weber. It's just as opposed to a ratcheted mechanism. But you can also use like what's called a sweetheart clamp. It will also be very helpful. And this is a regular size Weber, but on some patients who have smaller tibias, a medium sized clamp can work well. But so those are the probably two mainstays of clamps that I will use for this type of injury.
Bethany and Brandon, do you guys have any different clamps that you might use? Or you pretty much the speed lock Weber for y'all?
I use that exact same clamp that Jan has in that picture. My fluoro shots don't look quite as well reduced as Jan's, but that's the same clamp on there.
These are photoshopped. It's amazing what AI does these days.
I didn't get a chance to introduce Brandon. Brandon is on here by he is my brother-in-law, but he's also a very skilled orthopedic traumatologist at Mayo, and so he agreed to jump on to talk tibia fractures with us too. So thanks for jumping on, Brandon.
I'm only here so I don't get the worst seat at the table at Thanksgiving dinner.
Yeah, well, we'll see. All right. So let's see. How can I? Let's see. So here's your intramedullary nailing pictures. You put the screw in first, the posteromolar screw, or that A to P screw in first, Jan?
Yeah, I always do that first. I know some people say you're not going to displace the tibia fracture distally, but if you're ever in a room with a doctor or a surgeon who he or she does not want to do that, I would really encourage somebody to put like a K-wire or something distally. I've had one in practice displace, and it was after somebody said, "Oh, I've never seen one displace," and literally that was the case. Like in fracture rounds, I put a nail down and it displaced. So never again. I don't know about Brandon. What about you? Are you fixing those right away? Are you not fixing them?
Yeah, I do exactly the same thing for probably the same reason, which is like, what I mean, you're going to put something in it anyway. Why not do it when it's non-displaced and it's hasn't moved yet? It makes no sense to do it later, right? Just do it right away. Then you don't have to worry about somebody malleting the nail down into the diaphyseal scar and blowing that thing apart.
Can you talk a little bit about your targeted placement of the guide pin distally? I mean, are you just trying to get in the center? I mean, I see a lot of these where it ends up a little bit in the lateral aspect of the plafond. Like, what's your strategy for managing those, or for placement of the guide wire?
Yeah, can you go back to the other film? Oh, I didn't save an ankle film. Okay, sorry. Go back. Yeah, so great question. So this is a typical thing, and that especially I think for the reps to know where not only the starting point is, but where the end point is. And I try to aim for the center of the plafond and the lateral, and then I want to be slightly lateral to the center of the plafond on the AP, just slightly lateral, and that will help you improve your alignment with the use of the tibial nail. And that's just key to know where that is, because if it's off to one side, then we can use certain tools, like blocking wires, blocking screws to put that wire in the correct spot.
Yeah, I think that's a great point. And I think it's tempting to want to put it a little bit more medial than where it sits there. Here's a loaded question. What's the perfect amount of bend on your ball tip guide rod? Do you do it yourself, or do you trust someone else to do it?
Those are like personal questions. So, I'll say I trust anybody to do it. I really don't. I mean, I don't care.
You don't care that much.
I'm OCD about many things, but that's one thing I'm not about.
Okay, Brandon, that doesn't bother you either? Or?
Yeah, that doesn't bother me too much. I have, I mean, some people would say 0, right? 0 is the right amount of bend to put on it. Just put the thing down there straight. If it goes down, if you get the right spot on the starting point and you get right down the canal, it shouldn't matter where you go. But I bend a ball tip guide wire, and I have my, the tech that's in my room most of the time knows exactly how I want it, so that you don't end up getting it jammed inside there and you can't get the thing back out through the nail.
You can definitely
but occasionally get somebody. Yeah, exactly.
Bethany, what about you? Do you bend it, or are you straight? Oh, lost her. All right. Keep going. Okay, so here's your post-ops. I think that looks great. Your posterior mal is not displaced. Fracture looks well aligned. And just 2 interlocks distally here. Probably because it was a little bit more of a diaphyseal fracture, huh?
Yeah, and I very rarely use the third screw like I talked about before, because of that soft tissue irritation and so forth. So very rare now that I need it, unless it's for like a pilon.
Okay. So really curious about this question. So non-weight bearing, you keep these non-weight bearing, I'm assuming because of the posteromolar piece, or is this not correct? What's your weight bearing status in this case, Brandon and Jan?
If there's a posterior mal, I'm aggressive about weight bearing except for this fracture. I wait at least a couple weeks and then I start them weight bearing. I don't know why. I mean, no one's ever shown it. I've not had one displaced, and maybe that's why I'm not going to change my protocol.
Yeah, I would do the same, but I kind of do the same thing for all diaphyseal tibia fractures treated with a nail. I've had yet to, even like a totally transverse one that you nail and is totally compressed. Nobody, it seems like, ever actually puts weight on it right away. You know, they just have too much knee pain, too much leg pain, that they're kind of just gingerly stepping on it, even when you say weight bear is tolerated right off the bat. So for and occasionally, you know, people with tibia fractures do have wound complications, particularly open tibia fractures, which it seems like most of them are. So I routinely just say non-weight bearing till the wound's healed. Once the wound's healed, then we're going to go for it. But I'm doing that, you know, as you can imagine, mostly for soft tissue rest more than that non-displaced posterior malleolus.
Okay. And do you splint them? You guys splint them, or you just keep them in a soft dressing?
I splint it.
Jan, do you splinting too?
Occasionally, if I'm worried about the soft tissues, I splint it for like soft tissue rest. If their skin was like, you know, pristine, which is not usually the case, then I'll just put it like in soft dressing ace wrap. But if it's, I think people do better. I remember that was one of Hansen's thing. You know, if people had bad soft tissues around knees, he would cast them.
Yeah.
And I don't know, I still like take his. I mean, a few of the things I still do what he taught me. So that's one of them is soft tissue rest.
Soft tissue rest. All right. Yeah, especially for a lot
wound
of
closure, sir.
And make sure your Pulsovac is primed.
Yeah, that's right.
Oh, it's wild the things you remember, huh?
Yeah.
Okay.